Institute for Mental Health, and you are on the webinar that is being presented by Dale Jarvis on the Toolkit of Promising Practices for Financing Integrated Care in the California Safety Net. You should be able to see Dale's screen, and I'm going to turn it over to him in just a minute, and he'll go over how you can ask questions and kind of participate. Just to let you know, this is part of a series of trainings that we're providing for small counties. And there will be several others to come, and this particular one is part 1 of Dale's presentation. The next one, part 2, will be a week from today at the same time. So go ahead, Dale.
Hi, everybody. I recognize a lot of names on the attendee list. It's nice to see all of you here, or at least see your names here. As a bit of background, I worked on a toolkit last year to help folks get paid for integrated care, and this workshop is really going through that toolkit and giving you an opportunity to ponder it, hear what I think about some of what editorial comments I have about it, ask questions, and so we'll just see how this goes. This is really we did some face-to-face meetings, and we spent a lot of time in question and answer. So please feel free to ask questions. I'll explain how and when that's going to the Q&A part will work. But first, a couple things about the webinar itself. If you haven't done a lot of webinars, make sure there's 2 ways that you can connect with the audio. You can use your telephone, or you can use your microphone and speakers. And if you, I say here, make sure your phone is on mute except when you want to talk. We've put you all on mute, so that's actually not as important as it otherwise would be. But one of the things that sometimes happens is that people will click their, they'll call in with the telephone, but they'll click the use microphone and speaker button. And if you do that, by mistake, it creates a lot of feedback when I take you off mute. So what you want to do is make sure that if you're calling in by telephone, you click the use the telephone button on the dialog box. And if you're using the microphone and speakers, make sure that's clicked. Also, if you do use the microphone and speakers, make sure that you have a microphone on your computer as well as speakers, because if you don't have a microphone and you want to ask a question, we won't be able to hear you. There's 2 ways that we're going to do Q&A. There's several points during the webinar today where I'm going to stop, and I've got a little Q&A slide that will designate that. And you can raise your hand by clicking the little hand button next to your name, and then that will say, and I can see that, and that will give me the opportunity to unmute you and ask your question when we do the Q&A piece. Or you can type a question into the question dialog box, and you can, and I would just, you can, the easiest thing to do is to send to all. Click that, so you type in your question in the dialog box, you push the send to all, and that will come up on my screen, and that will allow me to see what your written question is. And you can do both. You can type in a question and you can raise your hand as well. So, and Shoshana and I will be monitoring the hand raising and the questions. Jumping into the webinar itself, I wanted to talk a little bit about the context for the toolkit and what I'm describing as the new healthcare ecosystem. It seems like change is coming quickly and change is coming slowly in California and around the country in terms of healthcare reform. And when all the dust settles, this picture is a little busy, but it's sort of Dale's take on how I think things are going to shake out. That the larger boxes denote where it says integrated delivery systems and accountable systems of care denotes that we're going to be moving towards really having much more integrated care than we have now, where primary care clinics are going to be taking responsibility for the whole health of the population, and not just treating folks after they get sick, but thinking about what they need to keep them healthy. And behavioral health provider organizations are going to be deeply embedded in that new ecosystem. And so the person-centered healthcare home is one term for medical home. It's going to be at the center, I think, of the new healthcare ecosystem. And there's going to be new payment models that actually pays for prevention and primary care and chronic disease management. And as I say here, a bonus structure for helping keep folks healthy. So if we all lived in England right now, probably everybody on this call would have a primary care doc that was in a medical home. And the primary care doc's salary would be, they would actually have they have a bonus system in a lot of clinics where the doc can actually get up to $100,000 a year in bonus if they hit their performance measures around helping keep people healthy. So this is no small potatoes in England, and that's what's coming to California in the United States at different paces in different states, and probably at different paces in different counties because of the way that the state of California is organized. Now, what I see happening, and why I have the red circle here around the person-centered healthcare homes, is there's a tremendous amount of integration that's happening where primary care clinics are being embedded in mental health centers, and mental health and drug and alcohol treatment providers are being embedded in primary care clinics, the bidirectional integration of care. And that's what we're going to be talking about today. But I don't want to start digging into that piece without thinking about the middle box, which is these health homes are going to be linked to high-performing specialists that can support the management of total health expenditures. And so right now, there aren't great links necessarily between a primary care clinic and the cardiologist and otolaryngologist and neurologists and rheumatologists and behavioral health providers throughout California. And what happens is when primary care docs make their referrals to specialists, historically what they've done is they've made those referrals, who do I refer my patient to, is based on their social network, who I went to school with, who I play golf with, who my friends are. And that's actually changing. And a doc in California, Arnie Milstein, has talked about, he wrote this article called Health Home Runs, where he talked about medical homes and that are actually producing service that results in 30% higher quality and 20 to 30% lower costs. And one of the things that he says is important that those clinics are doing is they're being very meticulous about the referrals that they make. And because they have these bonus layers systems in place, they're saying, okay, so who do I need to refer my patients to make sure that they get the right specialty care at the right time that has high quality that's going to help them improve. So what's happening around the country is as these health homes and primary care docs are being put into these bonus arrangements, they're getting very picky about the referrals, and they're being much more thoughtful about when somebody needs a referral to mental health or drug and alcohol. They're starting to be a lot more, they're paying a lot more attention to what the referrals ought to be. So in many ways, what's happening with the mental health system and drug and alcohol system in California, the trend that's happening is two things. You all are playing in the new healthcare ecosystem by becoming part of healthcare homes, and then by embedding yourself in those healthcare homes or embedding primary care clinics in your centers, and you're becoming making best friends with the primary care clinic from the perspective of you're a high-performing specialist. So that's something that may or may not be part of your strategic plans for 2012, but it certainly is coming. And the third box denotes that there's new payment models that are unfolding that I'm not going to go into detail now, but as we go throughout our time together over this week and next week, I'll be talking about what there's a whole chapter on the new payment models. In terms of preparing for this brave new world, I worked on a provider readiness assessment that you can download from the National Council for Community Behavioral Healthcare. We'll send out these slides. We'll make these slides available to folks. I think we can send them out to everybody who's registered for the session. And yeah, what this is. Shoshana, were you going to say something?
I just said yes, we can do that.
Great, thank you. And one of the things, if you Google mental health and substance use provider readiness assessment, it'll take you right to the National Council for Community Behavioral Health Care. And let me just, and what you can download is a PDF that that's the assessment, and it's designed for you to basically spend a couple hours reading through it, filling it out, and scoring yourself. And at the very end of the assessment, what you get is a scorecard that basically says, here's what my readiness is, and for each of 23 items, here's how I scored in terms of importance to my organization and my community. And what it helps you do is prioritize what you want to be working on to prepare for this brave new world. So that's an aside. That's a second tool in addition to the toolkit that we're going to be spending most of our time on today. Our agenda for today, let's see, sometimes most of you know me and know that I have an odd sense of humor, so let's see what I was thinking about. The meeting at 10. I'll send you a copy of the agenda, the hidden agenda, and your personal agenda. Okay. I'm going to do a little bit more introduction to the toolkit, and then I'm going to do a brief history lesson around community mental health centers, community health centers, etc. And then there's 8 steps to succeeding to putting together an integrated care project, and I'm going to talk about that. And as I've been working on this project, what we did was, in writing the toolkit, was we interviewed a whole bunch of folks around California who are doing integrated care. And we listened to how they put the programs together. We talked about the barriers that they ran into, and we basically wrote this stuff up. So what's in the toolkit really is the thinking of some of the best and brightest colleagues who are working on integration. And so we'll be then talking about tomorrow's payment models, and then the epilogue is called the customization of the medical home, and I'm going to be digging a little bit more into where I think health homes are headed, so that after next week you'll go away with a set of pictures and a set of ideas about how to tackle this issue of integration and getting paid for it. 6 chapters over 2 webinars. As we're going through the day or through the morning, I'd like you to be thinking about what is one question you'd like answered today, and what is one problem you'd like solved. So that those are sort of my frame-ups for taking time for fielding questions, either by you typing them in or raising your hand and asking them verbally. So let's jump into the introduction of the toolkit. First question that people asked when we started developing the toolkit was, what the heck are you doing this for? What's the purpose? What's the objective? And as we thought about it, it was actually quite simple, that we wanted to figure out how to ensure the California projects that are working on integration don't go bankrupt. And as we go through and talk about the barriers, you'll see that that's actually a pretty noble and important objective, is trying to deal with the barriers so that you can actually move into the future and still be solvent. There are two audiences for the toolkit. The first is provider organizations, and it includes mental health providers, substance use or alcohol and drug providers, and healthcare providers, answering the questions of how you navigate the existing funding maze. But it's also for payers, managers of care, including counties and the indigent health plans, and the health care deliveries, the health plans that are providing Medi-Cal managed care services. And for those groups, it's what can you do to create a more supportive and payment regulatory system both today and tomorrow. Again, because there's so many barriers, we really want to set up a situation where folks are really able to get paid and not go broke in the process. And because counties are both mental health plans and provider organizations, for those of you on the call that are from the California county, you're actually wearing two hats. We're also thinking about the folks that this toolkit is relevant for is across the continuum of those working on integration. Are you contemplating an integration project? Are you deep into planning the project? Are you well underway? We've gotten a lot of feedback from folks that this toolkit is actually relevant for all three groups of folks. And for folks that have been doing integration for a long time, what they found is that when they go through the steps, and they say, oh my gosh, I forgot a step. But it's not too late, and they can loop back around, and they can actually tackle that step. Or they may run across several barriers that they thought they were the only ones that were facing, and to know that other folks are facing those barriers and there's some solutions to those barriers has really helped them deal with some things, not right away, but sort of a little bit as they've gotten further down the road, so they're able in that way to loop back around and address the problems that they've been running into as their integration project has unfolded. Now, if you've read or taken a look at the toolkit itself, what you'll find very early in the toolkit is this quote, by all rights, every project should have failed. We have identified 10 major funding obstacles and chronicled countless stories about cultural differences, political hurdles, turf battles, personality clashes, and more. So read before proceeding. There's a little bump in the road sign icon. And then what we go on to say is, but my gosh, most all of the projects have succeeded because of people's creativity, people's figuring out how to work together in ways that they hadn't before. It's really quite stunning how successful the integration projects have been in California. And of course, we can't forget about the MHSA funds, which, especially the PE&I money, which has really helped these integration projects enormously. there are 8 chapters to the guide itself. And one of the things that we say in the toolkit is we were very almost Spartan around the writing of the toolkit so that you wouldn't have to wade through lots and lots of, blah, blah, blah writing. It really tries to cut to the chase on what's important. And we also suggest that you don't need to read it from cover to cover. You can jump around to whatever chapter that you want. You can skip chapters. You can focus in on just a particular piece. And it's written so that there's really, these chapters are all, to a large degree, self-contained. So what I found is that over the years, I've written a bunch of white papers and a bunch of policy papers and things like that. And I write it. I'm so excited about it. It's like, 40 pages long. Isn't that a great deal? Great ideas in there. But what it turns out is that everyone is so busy that if it's more than 4 or 5 pages long, people may print it out and put it on their shelf, but they rarely get around to it. And so don't think of this as like a 54-page document, but just think of it as a handful of very short pieces. And I think that will be helpful as you work on wherever you're at with your integration project. I'm going to move on to the next chapter now and talk a little bit about, I started working with community health centers back in 1975 when I was hired to be the financial manager of the Ann Arbor Free People's Clinic in Michigan. And we started a community health center in a low-income neighborhood in Ann Arbor. And so that goes back quite a ways. But if you think about the history of the safety net system, I really think about it as a tale of 3 siblings. And another reason why we have this toolkit is because it's really 3 safety net siblings that were separated when children. The health system, the mental health system, and the substance use systems all became these 3 separate silos with 3 separate funding sources. And if you think about where they're located, this is an org chart of the Federal Department of Health and Human Services with all the different buckets, if you will. And the health centers got stuck in HRSA, the Health Resources and Services Administration, while the mental health and drug and alcohol services got stuck in SAMHSA. And for many, many decades, these 2 departments or divisions never really related to each other much. They sort of saw each other as competitors for resources. They didn't play very well in the sandbox. And what we had was a situation where there really was very little connection around the rules, the funders, and the payers. The other piece that's important about this is that in 1982, President Reagan decentralized, he did this thing, it's called shift and shaft. I don't know if you've heard that term before. But what he did was Congress, with at his urging, spun the health centers and the mental health centers off to the states. That's the shifting part, and they cut the budget 20 to 30%, which is the shafting part. And but what happened was the following year was that the health centers were refederalized, and they were brought back in. It's the only time in the history of the federal government that a major program was defederalized and then refederalized. And so what we have now is a federal system of community health centers, Fqhcs, federally qualified health centers, but we have a 50 states, 50 sets of rules systems for mental health and drug and alcohol. And that's created even a larger gap between the 2 systems. And I'll talk about more as we go throughout our time together today. The community health centers started in the 60s actually, and 62 was the first piece of legislation, 64 was the second piece of legislation. So by the time 1975 came around and I started working with the system, they'd been around for more than 10 years. And they basically built up so that there were first community health centers and then migrant health centers, National Health Service Corps, and added on new designations for health centers. Healthcare for the homeless is one example. And they moved to a cost-based reimbursement system that's not too dissimilar to the short medical cost reporting system, with additional pieces being brought on in the 90s, basically free malpractice insurance, a new kind of payment model called prospective payment, expansion of funding under President Bush. And so there's been a tremendous amount of financial support for community health centers and political support, because it's one program where all the centers report up every year. You can actually go online and see 10 years worth of data around the community health centers for the whole country at a glance on one table. And this stuff goes to Congress every year to talk about how successful the community health centers are at actually serving the safety net. One other piece to note is that if there have been some studies that show that people that are served, who have Medicaid that are served in a community health center, have total health expenditures that are 30% less than people that receive their Medicaid care from a primary care clinic that's not part of the community health centers. So they have a very good reputation from that, from quality, equality, and cost perspective. As I said, the community mental health centers were defederalized, and I note that they were sisters of the community health centers in the early years, but they were part of that shift and shaft strategy, and they didn't get refederalized. And as I say here, it leaves success or failure up to each state's leadership and funding levels, and the ability of local behavioral health organizations to succeed in what I described as a highly regulated and underfunded environment. And the picture here is the NAMI report card that shows that as a whole, the national grade for health centers, mental health centers was a D, with California coming in, actually getting a C score, same as Washington where I live. Again, the importance of this is what we have are these two separate sets of regulations, two separate sets of funding rules that create very different operating environments. And when the mental health system attempts to participate in this health center world, it really is a completely different animal. For those of you that have community health centers, I know that you've it really is like moving. I've talked to a lot of folks. It's like moving to a different planet. So all this stuff is. Excuse me. I'm going to take a sip of water. So the separate wheels of change are happening in the safety net with the health centers and the mental health centers. But meanwhile, I would suggest that there's a huge amount of dysfunction in the rest of the American healthcare system that's created a huge sucking sound in the American economy. And, we spend going on $2.8 trillion a year on healthcare in this country. And huge amounts of money flow after you get sick to hospitals and expensive specialists that do work in hospitals. And primary care is underfunded, behavioral health care is underfunded, but even more importantly for us, the funding for the safety net for the mental health providers and the community health centers has taken a back seat to what I described as the centers of power. The insurance companies, the pharmaceutical companies, hospitals, et cetera, where most of the money is flowing. And so I've been thinking about this whole concept of sucking sound and centers of power. And so one of the things I did was I pulled together set of numbers, and I put together a little chart with a little couple of bar graphs, and see if you can follow through sort of Dale's brain on thinking about sucking sounds and centers of power. If you take all the community health center funding in the country for a recent year, it totals a little more than $9 billion. If you take all the mental health, community mental health center funding, which includes the drug and alcohol providers, it totals just under $20 billion. So combined, it's just under $29 billion. And the U.S. health funding is, as I said, almost $2.8 trillion. So that's only 1% of the total spend on health care goes to the mental health centers, the drug and alcohol providers, and the federally qualified health centers. But if you take everybody that's indigent and uninsured or has Medicaid in the country, that represents 22% of the population. So the reality is you're being asked to provide the frontline services for 22% of the American public with only 1% of the total funding. And these numbers are very similar in California if you break it down by state. But it really creates a situation where all this other money, like I said, is going to places after people get sick. In the business case for integration is we need to push more money into primary care, more money into behavioral health, so that we can actually create hospital and institution prevention organizations with these health homes and behavioral health and mental health centers, so that you're actually a critical part to fixing the healthcare system in this country, is actually helping people stay out of the hospital, stay out of nursing homes, stay out of IMDs, stay out of jails. So there's a very strong business case for mental health centers and community health centers to become best friends. And I see that that's already happening. Really the future is the head is being reconnected to the body. And your presence, you're really, as you're thinking about integration, what that's about is you're really on the leading edge of actually helping fix the healthcare system in the country. And one of the things that the Toolkit is designed to do is to help you be on the leading edge, but not the bleeding edge. I'm going to skip this slide here so that we can dig into some of the material around the actual 8 steps to creating a plan and start working on the barriers before our time runs out today. What I'd like to do now is have you stop and before I jump into the next chapter, have you think about, is there a question that you'd like to have answered today? Is there a problem that you're facing? I'm going to start my stopwatch and put myself on mute for about 1.5 minutes, and feel free to stand up and stretch or jot down a question in the question box or raise your hand, and before we move into the next chapter, I'll field any questions that people may come up with. So I'm going to start my stopwatch right now. We're starting to get some questions coming in, so feel free to, again, raise your hand or type in a question. And I'm going to come back to you in about 20 seconds. Okay. A few questions have come in, and we have some hands. So let me start with the written questions. The first one is there a limit on the number of Fqhcs in the given geographic area? The answer is kind of, sort of. And what that means, what I mean by that is if you want to if you want to become a federally qualified health center, or there's another designation, which is a federally qualified health center lookalike, you have to, well, first let's start with the lookalikes, because what lookalikes are is organizations that follow all the rules of becoming an Fqhc, but they don't get a federal grant, a 330 grant. They get the prospective payment system. They get to access the National Health Service Corps. So there's a number of benefits that they have. And if you want to become what a lot of organizations do in the process is they first become a lookalike, because you can apply to be a Fqhc lookalike at any point in time. And you don't have to wait for a particular selection process. There's periods of time when the feds open up and say, we're going to be adding more Fqhcs. And when you apply to, there's an application packet that's like 68 pages long that you can download. And if you want to know how to get access to it, you can Google Fqhc lookalike application packet, or you can drop me a line at dale@djconsult.net. Let me just dale@djconsult.net. And what they say, getting back to the question, is that you can set up a new Fqhc in a community where there are existing Fqhcs if basically two things happen. You get a letter of support from the existing Fqhcs, and you can demonstrate that there's still a need for another Fqhc. So if you can do those two things, get a letter of support from the existing Fqhc in the area, and demonstrate that there's still a need even though there are existing Fqhcs around, chances are you'll get approved. What's really nice about the application process is they go into great detail. They actually hold your hand and help you build the case. They say, here's how you build the case for creating an Fqhc. If you have any follow-up questions, just holler. The next question is, part of the challenge in providing the integrated care is the funding streams from California have significantly changed over the last few years, so that it's difficult to develop a strategic plan. Any advice or comment? So you know what's happening. If you think about what I think the thing to do is to first say, okay, what's happening now? Let's look at where things are headed over the next couple of years, and we can paint a picture about how the funding is evolving in California and for health and behavioral health. And what we know is that the age blind and disabled Medi-Cal folks are being moved into managed care. That basically everybody in Medi-Cal, there's 1.5 million folks in Medi-Cal that are in fee-for-service Medi-Cal for their health care, and they're all being moved into managed care. And so what that means is that health plans, Medi-Cal health plans, are going to be the payers, the major health payers in the ecosystem, especially as Medi-Cal expansion kicks in and the early expansion efforts, the LIHPs unfold. And so if you're thinking about doing anything in the healthcare arena, you want to be thinking about who are the Medi-Cal health plans in my area that are managing the care, the health services for people who have Medi-Cal. And understanding how they're operating and where they're heading and actually becoming best friends with them is in understanding how they operate does give you a lot of clarity about sort of where the payment models, the payment methods, the payment amounts are going to be in the future. And as we've gone into realignment phase 2, the mental health system and drug and alcohol services, the money is being pushed down, more money is being pushed down to the counties for that. So actually, the payment environment, while there's a lot of change going on, it really is the counties and the Medi-Cal health plans that are operating in the communities are really the funding streams that you want to pay attention to as you're working on integration. And what a number of folks are doing who work in the mental health system is they're making connections with the health plan saying, you know, we can help you save money as these complicated and expensive SSI folks start being managed by you. So let us be your partner. And so counties and other mental health centers are actually developing business arrangements with the Medi-Cal health plans. And so I think that those are really the two places to point your noses as you're moving forward with this. I'm going to take a question from the phone. I'm going to unmute Shirley Zhang. And Shirley, I've just unmuted you, and let's hope that we can hear you if you want to ask your question now. And if you're on mute, I can't hear you, or if you don't have a microphone, because you've logged in via computer, I can't hear you. Okay, struck out, sorry. Next question. Is there a web resource that lists the names and locations of all health centers? Yes, there is a web resource. There's in the HRSA website, there's a database of all the health centers in the country. And if we go back to the picture that I had that had all these dots, this map, this came from that website. What I'll do is I will put together I'll get the link and I'll send it out to you. Let me make a note. Have you heard about the reduction in Fqhc funding at the federal and state level? Right now, it is the cash cow that is driving system rearrangement, sometimes willy-nilly and without much thought. Is it possible that Fqhcs will give way to yet another structure for which we need to be prepared in order to continue the severely mentally ill consumer and families and kids? What's happening is that there still are increases. So let me start over again. So the amount of money going to federally qualified health centers has increased over the last 10 years fairly substantially. There was a huge amount of additional money that was built into the Affordable Care Act, and the cuts that are happening are actually cuts in the increases that were coming out, as opposed to cuts, real cuts to the system. So there's still more money coming into the Fqhc system at this point, just not as much more as what we were hoping. There's been a lot of pressure from the Fqhc community to try and reinstate some of that money, and there's been some successes there. In some states that provide additional state money for Fqhcs, as the budgets have gotten bad, states have cut funds. That's happened in Washington State. So there's, but on the whole, there's, the Fqhcs are still the game in town for safety net primary care. So then the question becomes, will Fqhcs go away? And there's a lot of people that keep asking that question and keep wondering about that. If everybody gets covered by insurance, and everybody has health coverage, and Fqhcs were designed to mainly help the underinsured and uninsured, do you still need them anymore? And what people are concluding is that Fqhcs are more than just a vehicle for addressing the needs of the uninsured and underinsured. They're a huge part of the primary care delivery system. And if the Fqhcs went away and all the docs were told just go get into a primary care clinic or some new model, we would lose a huge amount of capacity for people to receive, to have access to primary care. So the smartest people that I know of really see the Fqhc system as actually one of the bright spots for addressing the problem of how are we going to have enough primary care for everybody when 2014 comes and there's 32 million more people in the United States with Medicaid or private insurance coverage. I think that any change, any sort of having the Fqhc system go away is something that's probably not even going to be on anyone's radar screen for another 10 or 20 or more years. They're the game in town. And of course, I'm using a crystal ball right now, and I could be wrong, but that's what the smartest people that I know of are saying about that. Let's dig into opening the toolkit and how to get paid for integrated care. What we've done is we've said, you know what, if you were, let's pretend that everybody on the phone call is in the planning phases of putting together an integration project where there's an existing primary care clinic. And for purposes of my example, let's assume that there's an Fqhc in your community and there's a county mental health center that actually provides mental health and drug and alcohol treatment. And those two organizations are saying, we want to come together and do integrated care and figure this stuff out. All the other possible scenarios that are variations on that are still relevant, but I'm going to use that as my example as I talk through the 8 steps. What we found was that you need to start with ensuring, and of course this is kind of like a duh, that the top leadership is committed to the project and there's an identified project champion. And so as I say here on the slide, the senior leadership of the primary care clinic and the behavioral health system really need to make a strong commitment to ensuring the success of the project, and that they both follow through because of all the traps and challenges and how difficult this is. Where there is strong leadership who keep championing it, it makes a huge difference. And in addition to the leadership, there needs to be one other person who, as they say here, is a dedicated champion who has optimism, tenacity, attention to detail, and a belief that the project can make a difference. one of the problems that happens in a number of communities in California is somebody says, the mental health director says, or the Fqhc director says, we're going to create an integration project, and we're going to pick a couple people who are already working like a gazillion hours a week to be in charge of it, and just add this as another thing on your list, but keep doing everything else. And that's a real recipe for the project taking much longer and having a lower probability of success. If you really want to make an integration project work, you really need to have a champion. You need to have the leadership supporting the champion. You need to have champions on the primary care side and the behavioral health side. And I know it's kind of a duh, but if you don't start out with tackling step one properly, you're going to have problems. The next step is organize a planning work group and prepare a high-level timeline, project timeline. Oops, just a sec here. Technical difficulties. I've got some text on here that's not coming through, but so as I say here, healthcare is quickly moving from an individual to a team sport. And what folks have done that have succeeded is they've put together a multidisciplinary work group that's made up of local primary care, mental health, and substance use integration partners, the folks that are going to be integrating. And and what they've done is they've gotten both groups together, working together on the front end. And there's sort of two doors that those folks can go through when they start working on a project. They can spend 6 months putting together a timeline, and the project doesn't get started. It doesn't get started because they're so busy. Save that for later. That's a later step down the road, that you get the leadership together, you get a champion, you put together the work group, you put together a high-level project timeline, and then you get rolling. This may seem a little silly or obvious to put it into the work plan, but when you read the actual toolkit, it really says, it gives you some good ideas about how not to get stuck with the work plan and timeline. The third step that folks that are doing really successful work is they say, okay, so we've got this work group. We're going to develop an integration project. What we're going to do is design. The first thing we're going to do is we're not going to talk about the money yet. We're going to actually design the clinical model. And so this is a little workflow. I know how everybody likes flowcharts, so bear with me a minute. But this comes out of Washington State, where we've been working on behavioral health primary care integration in some very robust ways. And this typical workflow, which is being used in many parts of the state, basically says, here's how it's going to work. We have a new patient who comes in to see their primary care, and what happens is that primary care provider does a behavioral health screening. That's a new part of the clinical model. And if there's a possible behavioral health issue, we have a master's level person embedded in the primary care clinic, and they're going to do an assessment to see if this person really does need behavioral health services. And if they do need behavioral health services, what we're going to do is have a two-level model where the person will either get their primary care and behavioral health care in the primary care clinic. In Washington, it's called level 1. And in that case, it's interesting. What they have is people with low to moderate behavioral health needs are enrolled in level 1. They're case managed and served by a primary care team that consists of the primary care provider, that behavioral health coordinator, master's level, and then there's a consulting psychiatrist and other clinic-based, actually behavioral health providers. If the person has high, moderate, or high needs and really can't be in what the behavioral health care is more complex than what the primary care clinic can provide. There's a referral that's made to the mental health center or the drug and alcohol treatment provider, and that the PCP continues to provide medical services. The behavioral health coordinator is the glue that maintains the linkage to the primary care clinic and the specialty clinic, and this is seen as often as a time-limited referral with expectation that the care will be stepped back to primary care. So this is a model. It's called the impact model. I'm sure that a number of you on the phone are familiar with it, and you'll see why step 3 is important in a couple of steps. But if you don't design a clinical, so the point here is you design the clinical model so that, and you need to know what the steps are and how people are going to get care so that you can figure out whether these steps, the way they're organized, you're going to be able to get paid for it or not. If you haven't designed the clinical model, it makes it harder to figure out whether you can get paid for care. So this is a really important piece of the puzzle. And once you've designed the clinical model, what we're asking is, what we're suggesting is that you identify and address your funding barriers. And I'm going to go into that in more detail. That's what the next chapter is all about. But I thought I would play around with one of the things that we discovered around identifying and addressing your funding barriers. There's an analogy to, I don't know if any of you have ever been to Dubrovnik in Croatia, the former Yugoslavia, but they have this amazing castle that they've built, and the walls were, what it says here, the walls were considered to be amongst the great fortification systems of the Middle Ages, as they were never breached by a hostile army. And what we say in the toolkit is, if you're facing a similar financing barrier, either find a new castle to storm and move on to other ways to finance, or move on to other ways to finance your integration project. So one of the things, another way of saying that is, if you run into a barrier or what looks like a barrier, the first thing to do is to figure out whether it really is a barrier that no one else has surmounted, or look in the toolkit to see if there's ways that people have surmounted the barrier. And if it really is a barrier that you can't get paid for something, and I'll give you a whole bunch of examples in a few minutes, then just don't go there. And what that means is that your clinical design, you've created a clinical design that's set up in such a way that no one's going to pay you for it. And so it's really important to come up with the clinical design, see what barriers you've inadvertently built in terms of getting paid, and then either change your clinical design, i.e. avoid the barrier, find a new castle to storm, or if you can't overcome the barrier by learning from someone else, you don't need to change your design. I see that people are writing in questions, which is great, and I'm going to stop in just a couple minutes and answer some additional questions. So what happened? The way that you identify your barriers is sketch out the most frequent clinical workflows in your integration project, and you saw an example before. And then note, what you do is you note how each step in the flow will be funded or not. And there's 4 sort of big questions that this picture represents, are really the critical questions around whether you're going to get paid for the care. There's questions about who's receiving the service, who's providing the service, what is the service, and where is the service being provided. So what I'm talking about now is, if you're doing an integration project, if the person has Medi-Cal, Medicare, and or private insurance, of course, then you know that you have a chance of getting paid from this third-party payer or not, and if no, the alternative funding sources are needed. So you can ignore the other questions. But if the person has Medi-Cal, there's a bunch of rules around whether that provider can bill for care or not. And on the mental health side and on the Fqhc side. And we're going to go into some detail about that. So this is sort of like the setup for the next chapter. Certain people can bill the Fqhc system and certain providers cannot. Certain services are billable, certain services are not billable. Where the certain locations are, you can get paid for, other locations you can't. So you have to go through when you're doing you do your workflow, and the way that you identify your barriers is it the person, the client who's creating the barrier? Is it the provider in your design who's creating the barrier? Is it the type of service you're providing that's creating the barrier? Or is it the location of the service that's creating the barrier? These are very, very important questions. What happens a lot of times is people, I actually know a handful of places where they've started integration projects and they didn't do this work, none in California, fortunately, and the projects collapsed because they actually didn't do this homework in advance. It's not till step 5 when you've done your high-level work plan, you've done the clinical workflow, you have identified your funding barriers, you revised your clinical workflow to overcome the barriers, that you then design a detailed implementation plan. And one of the things that people are finding is most successful, there's 3 kinds of implementation approaches. A big bang, where they say, okay, we're going to start doing integration in every Fqhc in the county with all the providers on day 1. And what people have found is that that usually collapses because it's too complicated, it takes too long, or it takes too long to get up and running. The other 2 models that work a lot better are a single pilot, where you pilot an integration project in one clinic, or you have multiple smaller pilots where you have one behavioral clinician embedded in Clinic A, another one in Clinic B, or in that they're working part-time so that you're testing it out in different settings. What people have mostly been doing is a single small pilot and then expanding it when they get the kinks worked out, some multiple pilots, and then going and not doing the big bang, but ramping up very slowly. So this work plan, even though it looks more like a sort of art in terms of background art, and for me to talk about this, actually has real steps in it. And the manual you can look at it and hopefully read it. It talks about the kind of steps that you ought to follow to create a detailed implementation plan. I'm going to shift gears and look over it, see what kind of questions people have been writing in. First is, thanks. The thing I've heard is that capitation rather than fee-based reimbursement may be the norm as a cost-saving measure. And what's happening is that the prospective payment system is still in place for health centers in California. What it is it's a per encounter-based system. The California Primary Care Association is looking at alternative models to the prospective payment system. And there's a work group at the California Primary Care Association that's working at new payment models in California. And actually to know where they're headed is important in terms of knowing how the payment models may change for Fqhcs in California. And so that's an important tip to dial into what this California Primary Care Association is doing in their payment reform committee. Another person wrote in, just FYI, in the California MHIP description, Level 1 is the high-need patients, likely with chronic severe mental illness, and level 2 is the lower-need, briefer level patients. So in my workflow here, level 1 was low. In your design, level 1 is high. So it is a useful FYI to not get that mixed up. Thank you so much. Another question, what does behavioral health screening consist of? Is there a tool you might recommend, especially beyond the Fqhc, which only screens for depression? There's a number of tools that folks are using for this screening, and what I will do is I will send examples of the tools. And the person who wrote in is right that the Fqhc really is only a screening for depression. There's a tool called the ACORN that folks, especially in Oregon, but in a number of places around the country, are using. And then a lot of folks are using Scott Miller's tool around engagement. But let me do a little digging because I can't remember what they're using in Washington State, and this is that screening that the PCP does at the beginning to identify possible behavioral health issues. So I will get that out to everybody. One more question before I go on to the next slide. If billing Medi-Cal is the requirement that the service provider be a licensed clinical social worker, can they be an MFT? Can they be interns? Oh, I'm going to come back and answer that in the next chapter. There's actually the last two questions have been written in. I will come back and speak to in the next chapter. The next step, prepare a detailed integration budget. Moving on to step 6. So it's really quite simple. As you're working on an integration project, what you want to do is sort of go through 8 steps, if you will. How many people do we think are going to be served in the integrated care program? How much service will be provided to those folks? How many staff will be needed to provide that much service to those folks? And how much does it cost to fund those staff? What are the other costs, including startup costs? How much revenue can we generate based on the clinical design? Are we in balance? If not, then we need to change the design. So these are sort of the generic 8 steps for putting together an integration budget. And I want to show you an example on the next slide. Here's 2 different initiatives. One is the impact model, where behavioral health services are being provided in the primary care clinic following the workflow that I described. That's the yellow. And the second initiative is embedding primary care team in a mental health center. So let's look at each of these separately to think about how the budgeting works. So what we have is the primary care physician, that's a prescriber. All the services are being provided at the Fqhc in my model, in my example here, I mean. And what's going to happen is that primary care provider will continue billing through the Fqhc prospective payment system per encounter visits. So when they do that screening, when they provide medication services, that's just being encounter-based services. The second member of the team, the behavioral health professional, is they're doing care coordination and direct treatment. They're embedded in the Fqhc, but in this case, there's 2 ways you can go. You can have that person be paid through the Fqhc funding stream, Or you can have, in my example here, they're continuing to bill through the mental health center, and they're being paid through short-tail Medi-Cal for Medi-Cal folks and realignment for folks that don't have Medi-Cal. So in this case, what they found in this design, it probably was because that behavioral health professional was an MFT, not an LCSW. And if you're a therapist providing services in the Fqhc, you can't bill and get paid on a per encounter basis unless you're an LCSW or a psychologist, or a nurse practitioner or a psychiatrist. And so if a mental health center is embedding a behavioral health professional in the primary care clinic to provide services, and they're not one of those, they don't have one of those licenses, what you need to be doing is having that person continue to bill through the mental health system. So they're embedded in the primary care clinic, they're billing through short-tail Medi-Cal. It's just that where they go to work each day is a different place. It's the primary care clinic, not the mental health center. So that's just a few bars about that barrier. And the consulting psychiatrist is not meeting with patients in this example. What they're doing is they're meeting with, they're consulting with the team. And because, and so in this case, what they're doing is they're using PE&I money, MHSA PE&I money to fund that position. So they look at the role, the functions of each person, they decide who the best funding source is, and then that's how they build their budget. In this other case, where they're embedding a nurse practitioner, a nurse care manager, and a primary care supervising MD, into the mental health center, what they've done is they've expanded, they've applied to the feds to have the mental health center be a new site, and I'll talk about that in the next chapter. And then what happens is these three folks who may be embedded part-time or full-time in the mental health center, they're just billing back through the Fqhc system, and they're able to get paid for those services. So these are two examples. And so what they do is they basically build a budget to say how many people, how much service will those folks need, what kind of staff are needed based on the clinical model and the demand, and then how much does it cost to fund these positions. A couple more steps, a couple more questions. Then what we'll do is we'll end for today, and we'll pick up with the remaining chapters next week. Step 7, revise your infrastructure and obtain necessary approvals. The devil's in the detail. Does the health center require a change in scope of project? And what we're going to talk about next week is if a health center changes the services they provide, expands the type of services they're providing, the type of providers, and the places where those providers provide service, they have to go through, there's a fairly notable hoop called a change in scope of project that we'll talk about more next week. There's people have to confront the issue of who will own the charts, how will documentation be shared, will a shared patient registry be implemented that tracks key demographic utilization and clinical information and is available to the mental health folks and the primary care clinic folks. If you haven't heard of a patient registry, that's a really important tool that is being used all around the country on the medical side and is coming to a mental health center nearby. And it's a way to share data more easily than having to be on the same electronic health record. And one of the last examples of the devil in the details is, are we currently capturing the appropriate data in the primary care clinic and the behavioral health center to properly bill and be paid for services based on our clinical design? So these and other questions are things that need to be answered as you come up with your design. And there's so many examples of projects being derailed by the need for a sink, because if you're, and this goes to embedding a primary care clinic in a mental health center, and you know, it's not that hard to get an exam table. It's not that hard to get the medical supplies, but it's really hard in a lot of cases to actually get plumbing run to the room so that you can have the sink, which you have to be able to provide primary care services in the mental health center. So don't let the project get derailed because you didn't think in advance about the need for the sink, and that's part of the detailed implementation plan. And last but not least is go live. This is a rapid cycle improvement model where you test in a small scale. You figure out what's broken and you fix it. You test with a wider group, et cetera, and just go forth and prosper. And as I sort of jokingly say, the future is in rapid cycle improvement, not plastics. And if you haven't been using rapid cycle improvement methods in your clinic, in your organization, it's a really cool way to implement something in a simple way that increases the probability of success. That's the last slide that I'm going to cover today. There's a couple of questions that I'm going to make a copy of and save till next week related to MFT. I touched on the MFT question. I want to go into more detail about it. If feeling medical, does the assessment need to be as complicated as the specialty mental health assessment? I'm going to save those questions till next week. And let me just stop and see if anyone has any other questions for today. I know that it's really hard to listen to someone talk at you over the web for 90 minutes. So if we end a few minutes early, I see that as a plus. And I'm going to go into silent mode for about 30 seconds. How do you overcome the barriers like the culture of the organization to integrate after years of silos and separation? That's the shortest, let's see, there's lots of great experiences that people have had around overcoming the culture barriers. And the most pithy advice that I can give you is if you're going to do an integration, let me just assume that everybody on the phone call works at a county mental health center, just to keep it simple, and you want to do an integration project with a Fqhc in your neighborhood. The best thing to do is to have start an integration project on a small scale. When you meet with the Fqhc, the pitch is we can help you succeed. We can help your doctors get home for their dinner with their families more nights a week because we can help you deal with your most complicated patients. And so one of the first ways to start building the bridging the culture is to pitch how you can help the primary care clinic succeed. You can help the providers in the primary care clinics make their lives easier. And if you approach it with that from that perspective, you get a lot more mileage than any other perspective that I've ever heard of. And then the second thing is don't be overly ambitious. Really start out small with a small pilot and embed one person in the primary care clinic in the way that will be most helpful for that primary care clinic. So taking a real customer service orientation. And what you want to do is you want to find the most gregarious, relational, empathetic clinician who is really excited about this project, and embed someone with those characteristics. What's happened in a number of cases is mental health centers have embedded somebody who is kind of grumpy and not relational, and they don't make best friends with the primary care folks. What you want, the most important way to overcome the cultural barriers is to embed somebody who's going to make friends with everybody who works in the clinic. The single most important thing you can do is that, followed by the pitch being, we can help you make your lives easier. And I think if you sort of follow that very simple advice, you actually will have a much, much greater probability of overcoming whatever cultural barriers. The other thing to say is that the clinician that works in the clinic, the behavioral clinician that works in the clinic, they need to practice differently. They need to learn about how clinicians are working in primary care clinics, how it looks different than what their normal experience, their past experience has been, including being open to being interrupted by having a doctor open the door when you're in a session with someone to say, I've got someone here who needs help. And that's a really different cultural norm. And so learning about the cultural differences, learning about the expectations, and trying to accommodate is really important. I don't have any, let's see, will you address any implications with meaningful use? I'll make a note of that and talk about that next week. Primary care organizations have a definite organizational process. The recovery movement has moved away from the medical model, factory-style processing. The Fqhc model naturally tends towards this. Are there successful projects you know of that create a rapprochement between recovery rehab-oriented needs and challenges and the cost-effective provision of low, mid-level psychiatry with the Fqhc dollar? Because of the financial opportunities, it seems like the learning in mental health is at risk of being tossed out as we follow the dollar. Great question. What's happening is as people are moving into, as behavioral health folks are moving into primary care clinics, and as primary care clinics are realizing that they actually need to do more than just provide a visit and get people out the door every 10 or 15 minutes, but they're actually needing to help people move towards health, what they're finding is, what's happening is that the behavioral health providers are changing the culture of the health centers to be more recovery and rehabilitation oriented, because that's what's needed. If you're providing medical services to people that are seriously mentally ill and you don't take a more recovery and rehabilitated oriented approach, you're going to fail at providing medical services to them. So because if you just go in and blah, blah, blah at somebody for 7 minutes and run out who's got a serious mental illness, it's just like not having had a visit at all. So what we're actually finding is that the mental health clinicians are slowly changing the culture as opposed to having them become medical modelized. They're actually helping the health centers become more recovery-oriented, and that's how you keep people with serious mental illness out of the hospital. Is you help the culture, you model a new way of helping people with complicated behavioral health disorders. And so it's really cool to see that happening. I'm not saying it's just going to happen with the snap of the fingers, but that's the trend of what's happening more and more, and it's very cool, and it's very exciting to see that happening. It's actually the reverse of what one would think may happen. But there still is the time limits, and providers, doctors have 20 minutes to see a patient, not an hour. Nurse practitioners have more time, so there still are those pressures. Last question, and then we're going to sign off because we're pushing up against, and I'll pick up the remaining questions next week. In your flow chart of the clinical process, does the medical staff or the behavioral health specialist do the initial screening to determine whether behavioral health services are needed? Is every patient screened, and if so, how often? So those are really important questions. What happens is that when the model is working properly, it's the primary care provider, it's the medical doctor or nurse practitioner who does a very short screening. And like I said, I'm going to send some examples. And if it looks like that person may have behavioral health issues, there's a warm handoff, preferably in the same visit, the same day, to the behavioral health provider. Sometimes the appointment is rescheduled. There's a whole bunch of stuff to talk about next week in terms of the barriers. And the goal is for every patient who comes into the primary care clinic to be screened. And and that doesn't always happen, but that's the goal, because what we're trying to do is actually identify behavioral health disorders early rather than late and treat them, because what we find is that if you treat people even with mild and moderate disorders early, you actually save money on their total health care expenditure, and we'll talk about that again more next week. And in terms of how often different clinics have different models around that, sometimes there's a screening that's done, like if they have a physical or a comprehensive exam once a year with patients, and the Affordable Care Act is really pushing people having wellness checkups annually, then that's when the screening would be done. How often it's done there aren't any standards right now. It's varying greatly from clinic to clinic. I'm going to put a bookmark there. I'm going to save the question log and go through questions that next week that we haven't covered yet. And I want to thank you all for spending 90 minutes with me, and I hope to see you on the webinar next week. Thanks, everybody. Take care.
Thank you, everyone. Bye.
Thanks, Shoshana.
Thanks, Dale. Talk to you next week.
Okay, I'm going to let you all shut the webinar down.
Yeah, I'll do that.
So that you can stop the recording, and I will just sign off in a minute or two. Thanks. Bye.
Bye.
The organizer has ended the